So,
and we salute everybody who, doctor community who has lost their lives, and our special salute to you. And no doubt, when people say that the doctors are next to God, because the floodgates of heaven are opened up for the warriors as well as for the doctor community. So our salute to all the martyrs on Doctor's Day who have lost their life in fighting corona infection. So over to you, Rahul Jain.
Yes, ma'am. Really great work by all the frontline warriors, and it is so hard to be in those PPE kits. It is just a struggle every day. So, yes, afterwards, today we'll discuss a very interesting topic of hepatitis, which is of interesting concern over mostly all the major clinical subjects, and we'll study today hepatitis on this occasion of Doctor's Day. So, myself, Dr. Rahul Jain, and these lectures are happening under the guidance of Dr. Sharda Jain. So without much further ado, we'll start with the topic. So this is a basic structural framework that we'll be going through. That first we'll discuss definition, etiology, pathophysiology, and going over to clinical features investigation. And in the end, there will be a brief discussion over and detailed discussion over viral hepatitis. Then going on to the definition first. So when we talk about hepatitis, so the name only describes the definition. It is very simple. That is, it's the inflammation of liver. So hepar word is a Greek word which means liver, and itis is for inflammation, which is the English terminology. So it is inflammation of liver is hepatitis. So there are multiple causes of hepatitis, and it can be acute and chronic. So the deadline or the borderline for calling it acute and chronic is 6 months. So hepatitis. So etiology, again, which we have studied in other problems also, the etiology of anything can be described under the heading of vitamin. So same vascular causes, so ischemic hepatitis, congestive hepatitis. So ischemic hepatitis means when the blood flow to the liver becomes less, or congestive hepatitis seen in the case of...
You're not putting your screen, sir.
Screen is not. Yes. So happy Doctors Day to everyone. Today, this year, we have theme of Doctors Day as reducing the mortality in coronavirus, and salute to all those who are working in front lines. So today we shall discuss the topic of hepatitis on the occasion of Doctors Day, which is a very interesting topic, and we'll try to discuss it in very crisp manner. And myself, Dr. Rahul Jain, and these lectures are happening under the guidance of Dr. Sharda Jain. So this is a structural framework for today, that from definition, etiology, we'll go over to clinical features investigation, and in the end, we'll finish the discussion with the viral hepatitis a little more in detailed manner. Then coming to definition. So the word hepatitis is very clear and simple, that the word hepar is a Greek origin word, and it means liver, and itis means inflammation, which is English terminology. So inflammation of liver is hepatitis. So if we talk about inflammation per se, whenever we talk about inflammation in our body, it has 5 components. We say calor, rubor, dolor, tumor, and functional ACR. So again, in the case of hepatitis, we have all the 5 components. Calor means increased heat production at the site. Rubor means increased redness. Tumor means increased size. Then functional ACR means loss of function. And dolor means pain. We know that drug Dolo comes for pain, so dolor is for pain. So calor, rubor, dolor, tumor, and functional ACR. So these 5 things are characteristic of inflammation, and whenever there is inflammation seen over the liver, we call it hepatitis. It can be acute or chronic, and acute is less than 6 months, and chronic is more than 6 months. So 6 months is the cutoff. So this will be relevant to us when we'll discuss chronic hepatitis B and acute hepatitis B. So in those cases, we call it chronic hepatitis B when the duration of onset of the symptom will become more than 6 months. Then coming to etiology. So in previous videos also we had discussed that etiology of majority of diseases can be described under the mnemonic vitamin. So similarly, in this case also the same headings, we can describe the causes of hepatitis. So vascular causes is ischemic hepatitis, congestive hepatitis. So congestive hepatitis means the hepatitis which is caused by heart failure. So when the right-sided heart failure won't be able to pump the blood and take the blood from liver, so liver will get congested and will cause congestive hepatitis. Ischemic hepatitis, when there is less blood supply to the heart, maybe in case of cirrhosis. Then infections like viral hepatitis that we'll be discussing today, and there's schistosomiasis, even some bacterial infections, parasitic infections are also part of infections like amoebiasis and entamoeba histolytica, hydrated disease, and all those things. Toxins, carbon tetrachloride are very poisonous to liver, aflatoxins, alcohol we know majorly is poisonous to liver only. Then there's entity called as autoimmune hepatitis. Then metabolic diseases. So in Wilson disease, there is excessive copper accumulation, hemochromatosis, excess iron accumulation. Then iatrogenic diseases like tuberculosis drugs. All my tuberculosis drugs like isoniazid, rifampicin, and pyrazinamide. These drugs are majorly hepatotoxic, and they have a potential to cause hepatotoxicity, and out of these three, pyrazinamide is the most hepatotoxic. Then neoplastic like malignancies and even metastasis. Metastasis to liver are very common. So all these things can cause hepatitis and even hepatic dysfunction. So pathophysiology is very simple, that what happens whenever there is acute infection or acute inflammation over the liver will be overwhelmed by the cytokines and natural killer cells. And those cells will, since those hepatocytes will get infected by either the viral cells or maybe some inflammatory pathology, they will get destroyed by cytokines and natural killer cells, causing cholestasis. The chole word is for bile and stasis is for staying. So due to destruction of the infected hepatocytes, the bile won't be able to get secreted, and it will start getting accumulated in the body. So we'll study the symptoms related to it, that bile stasis will cause multiple symptoms like jaundice and itching and all those things. Then in chronic pathology, this will keep happening, and this will cause fibrosis, and that fibrosis will cause cirrhosis. So keeping it very simple, that in acute pathology, there is cytokines and natural killer cells, and they will cause destruction of hepatocytes, which will cause cholestasis and will cause all the symptoms. And when it keeps going on, then it will cause fibrosis, leading to cirrhosis. So clinical features. So yes, these are the clinical features which are common to majority of liver diseases, and for each clinical feature there is a reason. So when we say nausea and fatigue and vomiting, so the reason behind that there is nausea and vomiting associated with liver disease is that whenever liver gets affected, the toxins in our body don't get metabolized well. Those toxins will reach the brain and stimulate the vomiting center and will cause sensation of nausea and vomiting. Then associated with fever and weight loss, because liver is for all the anabolic processes. So whenever the liver dysfunction is there, all the synthetic protein function will go down and leads to weight loss. Then fever, since it will be an infection, all the cytokines will cause fever. Then itching. So this cholestasis will cause bile salt retention. So this bile salt, whenever it will go to skin, it will cause itching. Then right upper quadrant pain, because right upper quadrant is just overlies the liver. So whenever there's liver capsule inflammation, there will be right upper quadrant pain or abdominal pain. Even right upper quadrant tenderness associated with it. That whenever we press the liver over the skin over the liver, it will be tender. Then anorexia, the patient won't feel hungry. So yes, so these symptoms, whenever we encounter these symptoms, it should give us a hint that it is liver disease is a possibility. So we should rule out liver disease through liver function test whenever we see these symptoms, which are very non-specific, nausea, vomiting, and there are multiple causes of vomiting. We have discussed this in our video session of vomiting. So we should always rule out. And obviously right upper quadrant pain is very specific for liver pathology. Even gallbladder pathology can present as right upper quadrant pain. Then coming to jaundice, dark urine and light stools. So these three we'll just discuss in the next slide. And then hepatomegaly, that liver size gets enlarged. So whenever the liver span is more than 10 to 12 centimeter, it should suggest that it is hepatomegaly. And basically, the main formula we can use that whenever it goes below the rib cage, it might be large liver. Then yes, this diagram is the most important diagram, and once we understand this diagram, we can understand the liver pathology as well. So these 3 points, jaundice, dark urine and light stools, will get cleared with this slide only. So basically, what happens that red blood cells, whenever they get decomposed, they form, whenever the heme and the globin part get decomposed, the heme part ultimately form biliverdin, and that biliverdin will form unconjugated bilirubin. So the word unconjugated is very important here. So this unconjugated bilirubin is basically formed inside the peripheral blood. So when it will form inside the peripheral blood, so it is a product of destruction of blood cells, red blood cells. So any pathology which is pre-hepatic, that is like hemolysis of blood cells or anything like that, will cause accumulation of unconjugated bilirubin and will also cause jaundice, but it won't be of the hepatic origin, it will be of pre-hepatic origin.
Correct.
So unconjugated bilirubin is before liver. Then this unconjugated bilirubin enters the liver to become conjugated bilirubin. So the step of conjugation happens in the phase of liver. And one more important thing is unconjugated bilirubin. Unconjugated bilirubin is not water soluble, so it doesn't get excreted in the urine. So it never gets excreted in the urine. So this unconjugated bilirubin gets conjugated inside the liver, and conjugated bilirubin then gets excreted into the bile, and this conjugated bilirubin forms urobilinogen and stercobilinogen in the bowel. This stercobilinogen goes into the stool and urobilinogen goes to the kidney. So one important thing is, in a normal person, conjugated bilirubin will never come into the urine, while unconjugated bilirubin cannot get excreted into the urine. So that's why the bilirubin will hardly be present inside the urine in a normal person. While a person which is having normal biliary flow will have urobilinogen always in the urine. So these 3 points will give us idea with our investigation that what type of jaundice it is. Is it a pre-hepatic jaundice, is it a hepatic jaundice, or is it a post-hepatic jaundice? So I'll just revise one more because it is very important to understand this, that red blood cells will get decomposed to unconjugated bilirubin. This unconjugated bilirubin will go inside the liver to become conjugated bilirubin. This conjugated bilirubin gets excreted into the intestine. There it will get converted to urobilinogen and stercobilinogen. Urobilinogen can get excreted into gets reabsorbed and gets excreted to the kidney, and stercobilinogen gets excreted into the stools. So this one more point here, that whenever there is acute inflammation in the liver, there is hepatitis. This ability of the liver to excrete conjugated bilirubin into the small intestine gets really affected, and this conjugated bilirubin gets absorbed into the blood itself, and it does not get excreted, and that's why this conjugated bilirubin will go inside the kidney and make the urine dark and will not get excreted into the intestine and make the stools light. That's why we have dark urine, light stools, and this jaundice which will go and get also bind to the tissues wherever there is elastin, so skin and my sclera. So there is yellowing of eyes.
Okay.
So it's basically hepatitis which will affect the ability of liver to excrete the conjugated bilirubin into the intestine. So that conjugated bilirubin goes to the blood, and then it will go to the kidney. That's why there is dark urine, and since it is not going to intestine, there is light stools, and there is yellowing of the whole body because also it will go to the other tissues.
Correct. Very good.
So this hepatitis, 3 important things are jaundice, dark urine, light stools. Very important. Then coming to icterus. So I'll discuss jaundice more in detail to understand the basic how these things work. So this jaundice or icterus, first of all, definition is yellowish discoloration of sclera and due to hyperbilirubinemia. So why does sclera gets affected first in the body? There are 2 reasons behind it. First of all, sclera is white in color. So it is easy to pick up the yellow color whenever there is yellow color accumulation, bilirubin accumulation in the blood. And then second reason is sclera is very rich in elastin. So this elastin has very high binding capacity to bilirubin. So that's why there is yellowish discoloration of sclera first due to hyperbilirubinemia. Then jaundice is of three types: pre-hepatic, hepatitic, and post-hepatic. So coming to this diagram again, pre-hepatic means the cause is something before the liver. So one example is hemolytic jaundice. So hemolytic jaundice means unconjugated bilirubin will rise very high, but it won't affect the liver and it won't affect the intestine. So I won't detect any conjugated bilirubin inside the kidney because the liver function is normal. It will be only unconjugated bilirubin elevation. So that's when I should suspect that it is pre-hepatic jaundice or hemolytic jaundice. If it's hepatitic jaundice, we have already discussed the three classical features, that is dark urine, light stools, and also jaundice, and LFTs will be very raised. So LFTs will be raised of AST, LT, which is suggesting liver injury. Then the last jaundice is post-hepatic jaundice, when this bile ducts gets obstructed. So gallstone will come, obstruct these bile stones, and it will similar features will come, that is yellowing of urine and light stools. But one important point, one extra point will be that LFTs won't be raised that much and ALP will be raised too much. We'll discuss those things in next slide. So this is the basic way we differentiate pre-hepatic, hepatic, and post-hepatic. So yes, again revision. So history, examination, and blood test we will do when we are trying to differentiate the type of jaundice. So when we are talking about hemolytic jaundice, it will be associated with anemia, since there is hemolysis of the blood, and then there will only be unconjugated bilirubin rise. So first I'm going to pre-hepatic jaundice. Only unconjugated bilirubin will rise, and there will be normal LFTs. So that should give me a suspicion of hemolysis, and I should work up for hemolytic anemia. So this was the first thing, pre-hepatic jaundice. So pre-hepatic jaundice is for until unconjugated bilirubin, and we will follow this dictum that unconjugated bilirubin will rise, normal LFTs, and we should screen for hemolytic anemia. So I think pre-hepatic jaundice is very clear. Then moving on to hepatic and post-hepatic. So yes, again when I do history examination and urine analysis and blood test, it will give me a clue that in case of hepatic jaundice or in case of hepatitis, first of all, the unconjugated bilirubin will rise, and urine will be dark, and there will be stools will be light in color. Then I will do all this liver etiology screening, and I will try to treat the underlying conditions. So this conjugated bilirubin with rise in AST and ALT give me a hint that there is some liver injury and there is hepatitis associated. And then the patient will also complain of right upper quadrant pain, fever, and all those things. Then talking about the post-hepatic jaundice, so there are something called as polycytic LFTs. It includes my GGTs and my ALPs. We'll discuss about them further in the next slides. So they will specifically rise very high as compared to AST and ALT, and again the similar clinical features of light stools, dark urine, and itching can be associated. So again it should give me a hint of that there is some obstruction, and there I should do ultrasound and CT scan for gallstones and all those things. So that's how I basically differentiate between pre-hepatic, hepatic, and post-hepatic jaundice. And this diagram is the most important, will give us the crux. And so again coming to the point that normal physiology will always help us to reach in our pathological diagnosis.
Correct.
So coming on to the next investigation. So what investigations are in part of LFTs, and whenever we do, what do we expect in LFT, how do we interpret them? So first investigation is serum bilirubin. Normal levels are 0.13 to 1.3 mg per deciliter, and this total serum bilirubin consisting of unconjugated and conjugated bilirubin together. And normally when we talk about conjugated bilirubin, since we can see in this figure that conjugated bilirubin not much is there in the blood, and it won't there is no way this conjugated bilirubin can reach the blood. So the levels are normally very low inside the blood, and they are usually 0 to 0.2 mg per deciliter, and remaining 0.6 to 0.8 is my unconjugated bilirubin. So whenever we see a rise in specifically unconjugated bilirubin, it should give us a hint that it is hemolytic jaundice, and whenever we see a rise in both of the types of the jaundice, that is unconjugated and conjugated, then it should give me a hint that it is hepatic jaundice. And whenever I'm seeing only rise in unconjugated bilirubin, then I should get a suspicion that it is a type of post-hepatic jaundice. So serum bilirubin is the first investigation which will help me to detecting the type of jaundice that is unconjugated, that is pre-hepatic, hepatic or post-hepatic. So only unconjugated, pre-hepatic, both in hepatic, and only conjugated in post-hepatic. Then coming to serum enzymes, that is AST, ALT and AST-ALT ratio, ALP and GGT. So these are the 5 enzymes we'll be discussing about. So first is AST, that is aspartate transaminase, and or I call it in older terms serum glutamine oxaloacetate transferase or transaminase. So basically what is happening is normal levels for both AST and ALT are more over 10 to 40 international units per liter, though ALT sometimes is little higher, but it's 10, we can take the normal levels 10 to 40 international units per liter. So what is to be remembered here is that AST is not specific for liver, while ALT is very specific for liver. So AST can rise in hepatic injury, muscle injury and heart failure, all three. So AST can rise in hepatic necrosis, muscle injury and heart failure, but ALT will only rise in liver injury. So it is very specific for marker for liver injury. So ALT ratios are most, so whenever I'm talking about AST ALT ratio, if the ratio goes very low, that is below 0.8, then it should give me a hint that it is a case of liver injury specific to liver, because ALT, we can remember it as that ALT has the word L in between, so L is specific for liver. So one mnemonic cue here that
this is a very specific question. You should know the interpretation, that's it.
Yes ma'am. Then AST and ALT ratio, normal ratio is 0.9 to 0.1. So if ALT will rise further, the ratio will fall, and which will indicate liver injury. But in case of alcoholic hepatitis and cirrhosis, it is the opposite. That is, the ratio is higher and ratio reaches 2 to 3. The reason is there is decreased ALT production. And why this ALT production is decreased? Because ALT production requires pyridoxal phosphate. And this pyridoxal phosphate is deficient in alcoholics. So this alcoholic hepatitis, it is opposite, that the ratio rises and AST is higher, and the reason is ALT production is very low, and due to decreased pyridoxal phosphate levels in the body, and alcoholics are deficient in pyridoxal phosphate. Then coming to the last 2 more enzymes we will be discussing, that is ALP and GGT. So ALP is a canalicular and is presently canalicular and sinusoidal walls of liver. So whenever there is anything which irritates the canalicular and sinusoidal walls and even my cystic duct and hepatic duct, then these levels will rise markedly, and normal levels are 80 to 240. So ALP is very specific for post-hepatic jaundice. So whenever this here, after gallbladder in this ducts and all, whenever there is something irritating, gallbladder or something like that, then it should give me a hint that it is a case of post-hepatic jaundice. So one more important thing is GGT. So gamma GGT is very important. This ALP is also present in bones. So suppose we see a case of only ALP rise, and we are not able to decide that if this ALP rise is due to liver rise or due to bone disease rise, then I should check GGT. So if GGT is rising with ALP, then I know it is because of the liver cause. But if my ALP is specifically only ALP is rising and not GGT, then I know that it is due to the bone problem, not the liver problem. Then GGT is a very good indicator of acute alcoholism. So if I see only specifically GGT rising in someone's blood, then I can be pretty sure that the person is a chronic, is doing acute alcoholism. He has just had a drink, maybe just before the test or a day before the test.
Rahul, will you repeat GGT again in alcoholic cirrhosis?
Yes, ma'am. So I think till AST and ALT we were clear about the hepatic jaundice. that is hepatic jaundice, both will rise because the liver injury is there. But when I'm talking about post-hepatic jaundice, that is, there is jaundice affecting the ducts. That is due to gallstones or maybe because the bilirubin is not able to get excreted into the intestine. So when I'm talking about the post-hepatic jaundice, it is so there are two enzymes which I will see. One is ALP, another is GGT. So ALP is present in canalicular and sinusoidal walls of liver, and whenever there is something irritating those walls, it will cause a rise of ALP. So and it will also cause rise of GGT. But ALP is also a marker of bone disease. So whenever I see specifically only ALP rise and not GGT rise, then I can say it is because of bone disease, not because of liver disease. But when I see GGT also rise, then I'm sure that ALP rise is due to liver, associated with liver problem, not only bone problem, or maybe there is no bone problem. Then if I only GGT rise, then it is an indicator of acute alcoholism. So the person must have drank alcohol within last 2-3 days of getting a liver function test done. So that way I can tell that some person is drinking or consuming alcohol while doing. I can do only specifically gamma GGT will rise in case of alcoholism. So this much only about the serum enzymes. So one more thing, that basically why the serum enzymes are rising, that these enzymes are present inside the cells. So whenever there is cellular injury, these enzymes gets released. That's why they are rising in the blood. Then coming to plasma proteins. So plasma proteins, we have total proteins, we have serum albumin, and we have serum globulins. So serum albumin, the normal level is 3.5 to 5.5 gram per deciliter, and total proteins are 6 to 8 grams per deciliter. So serum albumin 3.5 to 5.5 gram per deciliter, and it is an excellent marker for hepatic synthesis function. So we realized something, that liver has multiple functions. So one function was excretion of bilirubin and processing of bilirubin. So that I can detect through serum bilirubin. Then hepatic necrosis or hepatic injury I can detect through serum enzymes. Then coming to hepatic synthesis function, I can detect through serum albumin. So this is an excellent marker for hepatic synthesis function, and very low levels of serum albumin indicates severe damage, and it is not a good prognosis. And also all the chronic inflammation, including tuberculosis, the serum albumin will be low. So maybe isolated serum albumin low in a patient with history of weight loss, maybe history of appetite, and investigation all normal, I can suspect that there is a possibility of tuberculosis. A thin, frail individual, malnourished individual. So again, serum albumin is in India specifically, because tuberculosis incidence is very high. So it's a very relevant in chronic inflammation, serum albumin. Then serum globulins are normal levels of 1.5 to 3.5 gram per deciliter, and they get increase in liver disease. They are just compensatory increase due to fall in case of serum albumin. So whenever the fall in serum albumin, the body will try to normalize the total body protein levels by increasing the serum globulins, and serum globulins do not get produced in liver. They get formed due to plasma cells. So that's why there is increase in liver diseases. Then coming to coagulation time. So coagulation time, so we need to remember that prothrombin time is basically extrinsic pathway, and it is the coagulation time which we want to measure to see the function of liver, and liver produces all coagulation factors except factor 8. So factor 8 is part of intrinsic pathway, and other factors are part of intrinsic pathway. So intrinsic pathway means factor 8 is part of intrinsic pathway, and other factors are part of extrinsic pathway, which is part of prothrombin time. So we measure only prothrombin time to check the coagulation function of liver. So if we see APTT and PT, and APTT will rise when there is factor A deficiency, but PT will rise when there is liver function abnormality. So PT will check for coagulation time and for liver function. Then coming to fasted lipid profile, that there are multiple cholesterol, triglycerides, HDL, LDL levels, which we check as a part of liver function test, because all the lipid metabolism gets through our liver. So, then finishing over the investigations, and hope investigations are very clear and crisp.
Oh, yes.
And we have tried to make it very simple that we divide the investigation basically serum bilirubin, serum enzymes, plasma proteins, and coagulation time and fasting lipid profile. And we have also discussed significance of each, and they give us idea about the different function of liver, and on the basis of specific abnormality we can say that okay, this function of liver is getting affected, or maybe this is the issue, and then we try to treat the cause. Then coming to viral hepatitis, today, first of all, there is not only hepatitis A, B, C, D which are causing viral hepatitis. When we are discussing viral hepatitis, we are discussing about all.
Rahul?
Yes, ma'am.